Hello, everyone, and welcome to the third webinar of the Helios Speaker Series. Just to give you a very brief overview about Helios, because a lot of you might already be familiar with the work from Helios. So Helios aims to improve the care for hemoglobinopathies by bringing together world-leading experts to provide training, capacity building, and networking opportunities, and to really drive forward key activities to improve the care for hemoglobinopathies. Whilst the focus is mostly on Europe, we currently have over 200 members from literally all over the world. And if you want to find out more, if you're interested in joining, go to our website, heliosaction.eu. On our website, you also find more information about this Helios speaker series. Our next speaker, Anoushka Schipper, will speak about the use of AI to predict hemoglobinopathies. And it's really important you register for each webinar individually. You can't register for the series, but you really have to register for each individual webinar. You also find the recordings of the webinars on our website. The last ones were with Sophie Landskron and Dr. Oyesola Oyewunmi. So if you want to have a look at those as well, in case you missed them, then you find them on our website as well. And today I'm very delighted to welcome Dr. Kristen Howell from Texas A&M University. Kristen is a chronic disease epidemiologist with a particular focus on the transition from pediatric care to adult care for young sickle cell patients. Kristen got a bachelor in biology from the University of Oklahoma, a master in public health and epidemiology from Emory University, followed by a PhD in epidemiology from the University of Memphis. And before becoming a professor at Texas A&M University, Kristen worked as a clinical scientist at St. Jude's Children's Research Hospital, and she still very much enjoys using her experiences from her work in the hospital in the classroom to highlight the importance of the work as an epidemiologist with her students. And today I'm very excited to welcome Kristen to talk about her recent publication about the impact of the transfer gaps from pediatric care to adult care on the use of healthcare resources. And Kristen, thank you so much for joining today. I'm very excited about your presentation. I'm sure all listeners are too. And over to you now. Thank you.
Wonderful. Thank you so much for having me, Stephanie. I will get my screen shared. Can you let me know if you see everything right?
That's perfect. Thank you.
Wonderful. Okay, so as Stephanie said, my name is Kristen Howell. I'm an assistant professor at Texas A&M University in the Department of Epidemiology and Biostatistics. So I am very excited to present this work to you today and get your feedback and have some discussion, hopefully, about healthcare transition and sickle cell disease. I do not have any conflicts of interest relevant to this work to disclose. So today I'm going to talk a little bit about the motivations of the work, really how I got involved in this work, where it all started out for me, and what inspired the study. So we'll talk a little bit about sickle cell disease and healthcare transition, some of the barriers to transition. We'll chat about that, and then talk about the study findings and implications of the study. So how I got involved in this is really by the work of some of incredible mentors who have stepped in my path and helped kind of guide and direct me. So as Stephanie said, I earned my PhD from the University of Memphis, and as I was trying to figure out where I wanted to go for school, St. Jude kind of kept coming to the top of my passions, somewhere that I always really wanted to work. I've always been very inspired by the mission of St. Jude of finding cures, saving children. It sounds like a very simple mission, but is obviously very complex. And what I've come to find out is everyone who works for St. Jude from the top to the bottom is very motivated by that mission and very inspiring to work in this facility. So again, as I was trying to decide where to go for school, I decided to go to the University of Memphis, where St. Jude is located in downtown Memphis. So the hopes was that I would be able to get connected with St. Jude, and fortunately enough, that's exactly what happened. I was advised by Dr. Smeltzer and Dr. Nolan. They both had previously worked at St. Jude, and now Dr. Nolan has since returned to St. Jude, and so I was able to be mentored by them, and their connection to St. Jude was through the hematology department. And so that's where I started working with Dr. Hankins. She's a hematologist at St. Jude, and started working in the field of sickle cell disease. So Dr. Hankins sat on my dissertation committee, and this project is actually one of my dissertation projects. So I'm really excited to talk through that with you guys today. I also met Dr. Porter, who is a psychologist at St. Jude and works with sickle cell patients. And so I was able to do a postdoc with her after I finished my degree. So very fortunate that this is the path that I ended up on. Obviously, it was kind of following my dreams. And so I'm really thankful. Part of working at St. Jude, one of the parts that was most inspiring to me was that we have the opportunity to interact with patients. And through working with Dr. Hankins and Dr. Porter, they allowed me to get to interact with these patients and get to sit down with them and talk with them about their life experiences, the challenges that they faced. And I've found that oftentimes as researchers, it's easy to kind of get stuck in our bubble, stuck behind a computer, and easy just to, we think of population-based research, and it's easy to kind of just see these patients as zeros and ones on our data set. And so being able to work in this facility where we see the patients, we're interacting with them, really helps to bring that passion back to the front, and change that mindset of, we're studying the population, but at the end of the day, included in this population are individuals and their stories matter. So I'm very fortunate to have that experience. And so that is something that I do like to bring into the classroom, of reminding my students that, yes, we are studying the populations, but these individuals are very important, and each one has a different story. And so very thankful for this opportunity to work there and kind of get to live that dream. And now I kind of have the best of both worlds, being able to work with students, but also still be able to collaborate with St. Jude. So very thankful for that. This bottom picture is with Dr. Hankins when we presented this work actually at ASH a couple of years ago. So thankful that this is now out in print, and now we can discuss more fully with you guys. So we'll get into a little bit of this. I imagine that most of you are very familiar with sickle cell, so I won't go too much into the nitty-gritty details, but just a brief overview. Sickle cell, it's a recessive inherited disorder of the hemoglobin. It's causing our red blood cells to take a sickled shape, and then these sickled cells are very sticky. They often are impairing the blood flow, causing vaso-occlusion, and so this can end up in organ dysfunction and several complications. So it's a multi-system disease, so it's affecting, promoting damage throughout the entire body, and all organ systems are involved. So this can result in both acute and chronic complications all over the body. So if we kind of take a little bit of a dive back into history, the 1960s, sickle cell was referred to as a disease of childhood. It really wasn't expected that patients would live past age 20. And so fortunately, due to newborn screening protocols, different advances in treatment and disease management education, we've made huge strides in the expectation and survival for these patients. So as we see, we're kind of marking these trends over the years. So this black line is 1979. And so we see that bimodal distribution where we have that early peak of mortality in early childhood. And so we've seen that has come down significantly. So the green line is 1999. So we see that peak of early mortality in childhood go down, but we are still seeing this rise of mortality in young adulthood. And so this 2017 data in red, we're still seeing where this peak of mortality starts to rise in young adulthood. So this age group 20 to 34. And so, yes, we've made huge strides in pediatric care and early childhood. However, we're still seeing a lot of deaths in young adulthood. And so this period of life is extremely vulnerable. And so this young adult years is something that's been a major focus in the United States for sickle cell care. So if we start to think about what's happening in the body during this lifespan of a patient with sickle cell, thinking back from infancy, the different complications we can expect to see: stroke, sepsis, aplastic crises. So we can expect to see, a few different complications come up, but as they age, this list of complications just increases and increases. And so we start to see several more complications come up as they age. So these acute and chronic complications really increase as the lifespan goes on. And so again, this is just an extremely vulnerable time in these young adult lives of patients with sickle cell. And if I put myself on this page and I think, what am I going through during this time point from adolescence to young adulthood? What happened in my lifespan as someone without a chronic disease? It was already a very stressful period. I was graduating high school, trying to decide where to go for university, trying to decide about occupations, and gaining that independence from your parents. And so it's already an extremely stressful and vulnerable time. And then to add on a chronic disease on top of that, it just seems unfathomable. So it's an extremely vulnerable time, very stressful period for young adults and adults with chronic disease, and especially with sickle cell. So if we think about healthcare transition, so what exactly does this mean? So it's defined as the purposeful, planned movement of adolescents and young adults with chronic, physical, and medical conditions from child-centered to adult-oriented healthcare systems. So when you first think about healthcare transition, maybe it's easy just to think about, oh, they move from pediatric care to adult care. It's as simple as that. How hard can it be? But it's actually a very long process that we've come to find out it takes a lot more than it's not just the simple movement. There should be more things involved. And so fortunately, these healthcare transition programs have started to really take off. And it's not a process that's at all unique to sickle cell. This really is for any young individual with chronic conditions. And so it's important to tailor these programs to that condition. And so at St. Jude, they have developed this healthcare transition program that starts as early as 12 years old. So I like to think of it as 3 chunks, so 3 phases of this process. So first, starting with preparation at St. Jude, like I said, they start at 12 years old, and it's honestly a lot of education at this point. We don't want them to turn 18 and realize at the moment they turn 18, oh, surprise, you need to move to adult care. We don't want that to be a surprise. It needs to be, they need to be prepared for that this is coming, that this is a change that they can expect. Oftentimes, these individuals, they're diagnosed as newborns. They may have even had the same doctor, the same facility likely, but maybe even the same doctor since they were a newborn. So to kind of get that shock of, oh, now I have to find a new doctor, I have to go somewhere else, it's very daunting and alarming. And so if we can start that preparation early to let them know that this change is coming. And so it's not even just preparing them that this transfer is coming, it's preparing them with a lot of life skills. They need to understand different skills. Having a chronic disease, there's a lot of different things that come with this. And so they need to know how to make their appointments. Maybe as children, their appointments were always made for them. Maybe their parent did it. Maybe the clinic itself, had a schedule and they, had everything scheduled for them. They never had to do this on their own. So we're training them how to call and schedule their appointments. We're training them how to read the prescription labels on their medication. If we say that if their prescription bottle says take twice daily, what does that mean? Does that mean take 2 in the morning? Does that mean take 2 at night? Does it mean take 1 at 8 a.m., 1 at 8 p.m.? They need to understand how to understand that dialogue on their prescription bottles. Also, they're learning about their insurance and how exactly this works. And so there's a lot of different life skills incorporated in this preparation phase. They're also learning more specifically about their disease. So we're training them of what exactly sickle cell is, what complications they can expect, what how to manage their disease at home, if they're able to, hydrate more, or what tactics they can use to improve their care just at home. So just making sure they really understand what's happening in their body. We need to make sure that they understand what the disease is. That way they know how to advocate for themselves whenever they become adults. So that's the whole preparation phase. So like I said, it's a huge process. And so this can begin early on, and at St. Jude tries to begin around age 12. So that's the preparation phase, and then they move into the transfer phase, which really that is the physical movement. So we've prepped them, they turn 18, and then we physically transfer them to the adult facility. And then the last phase is that integration phase. And again, this can be a few years also, where we're making sure that they feel fully integrated in care. They don't just make their first appointment and not go after that. It's important that they continue with care, that they're seen by their adult provider, and feel fully integrated into that facility. So healthcare transition is a huge process, and it's not just that physical movement. There's a lot that goes into it. So when we think about healthcare transition, like I said, as a young adult without a chronic disease, you're going through several stressors, such as finding, an adult care provider. You're developing independence from your parents. You're learning how to deal with your insurance. So there's several stressors already going along during this time point, but there's a few more stressors and a few more barriers that have been identified, and so I think it's important to discuss these. One of them is systems of power. So this has been reported to be a common barrier, and this is really referring to policies, different processes and practices that can influence your access to resources, access to different opportunities to be healthy. So there may be different institutional or practitioner biases that may be affecting this individual's ability to access care. So these are really important to address for healthcare transition programs, to be able to prevent this barrier as much as possible. Another barrier we've heard is that patients feel like they're not knowledgeable enough about transition. So maybe they don't feel prepared enough. And so that may make them hesitate to engage in transfer, because they don't feel ready for it. They don't feel like they know enough. They can't advocate for themselves yet. So it's really important that they have that knowledge base, and they feel ready to be able to advocate for themselves during this transition process. Another thing that has come up a lot is these challenges in coordinating care across different providers, different institutions. So this communication between pediatric providers and adult providers can be really complicated if there's not an established relationship. So again, during this healthcare transition program, if we're able to establish that relationship and make that as smooth as possible from the patient perspective, that would make this a better process. So again, other examples could be health insurance coverage. That obviously can be a huge barrier. But it's really important that these transition programs are in place, and they're considering all of these different barriers to make sure that we're effectively preparing the adolescents for transition and making this process as smooth as possible for them, and ultimately providing that continuity of care during this really vulnerable time for young adults. So if we're wondering, what exactly is a successful transition, this can be really difficult to define. And so instead, kind of different angles that we've taken to look at this is just looking for different indicators of a successful transition. So different indicators we could think about are adherence to treatment therapies. So if they're using a specific treatment, maybe it's hydroxyurea during pediatric care, and then they move to adult care, we want to make sure they're staying adherent to that. We've seen, if you take breaks from using hydroxyurea, things can spiral south pretty fast. So we need to make sure that they're adhering to that. And if we see that they have this adherence, this continuation of the therapy, then maybe we could consider that a successful transition. Another thing to look at would be the stability or improvement of disease severity from pediatric care. So if we can kind of measure their disease severity and pediatric care and see, are things getting better, getting worse, or staying the same? If we can see that stability or improvement, again, maybe we can consider this a successful transition if we don't see things getting worse during adult care. Something else to look at would be outpatient clinic attendance. So if they are routinely being seen by the adult provider after transition, then maybe we could consider that a successful transition because they're under constant follow-up. We don't have that discontinuation of care. So outpatient clinic attendance might be an important indicator as well. So if we're trying to kind of make a theme around these and summarize this up, I would say this is establishing and remaining in care during adult care. So not only are they, making their first initial adult appointment, but they're also staying in care. They're being followed up. There's not this large gap in care over time. So overall, when we're thinking about a successful transition, I think that's something that we can look toward, is this establishing and remaining in care. So when we think about current recommendations for this period, we've seen different professional societies and healthcare experts recommending that adolescents with chronic disease, again, this is all chronic disease, not specific to sickle cell, that the maximum period between their last pediatric visit and their adult care visit should be 6 months. So at most, there should be a 6-month gap between their last pediatric visit to their first adult visit. And again, this is just for all patients with chronic disease, not specific to sickle cell. And so we hadn't seen any evidence backing up this recommendation. And so that is really the drive behind this study, is to determine if this 6-month period is the best call, is the best recommendation. Even though this recommendation exists, we still see transfer gaps longer than 12 months. So being able to have evidence to back this up, maybe we can help inspire providers, inspire patients that this should be a good goal and that they should meet this goal. So I want to make sure that we understand the different terms. I know transition, transfer can kind of get a little bit confusing. So again, we're talking about the physical movement from pediatric facility to adult facility. So this is the transfer gap, defined as the time between the last pediatric visit to the first adult visit. So that is the transfer gap. And then the whole transition period can span several years, beginning all the way from transition preparation and during pediatric care all the way through to being fully integrated in care. So it can get kind of confusing mixing up transition and transfer. But for this study specifically, we're just looking at that transfer gap, so that time between their last pediatric visit to their first adult visit. And so again, for this study, we're interested in that transfer gap and specifically analyzing that 6-month transfer gap recommendation. So we hypothesized that transfer gaps longer than 6 months would be associated with higher frequencies of acute healthcare utilization and lower frequencies of outpatient visits in adult care. And so we did this by conducting a retrospective cohort study. So we included participants who had completed pediatric care at St. Jude between 2012 and 2018, and those who had already fulfilled their first adult visit. So this does mean we had to exclude patients who had not completed transfer. We needed to know exactly how long their transfer gap, that was important, that was crucial to the study. So we did have to exclude anyone who did not fulfill their first adult visit. And then we followed our participants retrospectively through the end of 2020. So since there was a range of time between when they completed their last pediatric visit between 2012 and 2018, and then we followed them through 2020. So there could be a minimum of 2 years. So if they completed pediatric care in 2018, we followed them through 2020, minimum of 2 years, and a maximum of 8 years. So there was a range of follow-up here. So our exposure of interest, of course, is that transfer gap defined in months. And so we separated this up into 3 groups. We had less than 2 months, 2 to 6 months, and more than 6 months. And again, that's the current recommendation, is the 6-month mark. And then our outcome of interest was the healthcare utilization in adult care. So we looked at all routine outpatient visits in adult care, inpatient hospitalizations and emergency department visits. And we modeled this using generalized linear models using the negative binomial distribution. So that was to take into account the number of follow-up time and be able to provide the incident rate ratio of visits in adult care. And we used multivariable models, so these were all adjusted. So to just give a glimpse of how many participants we had 183 participants in the study. 51% were male, 67% had a more severe genotype, so HBSS or HBs beta 0 thalassemia. And then our transfer gap, we had majority of participants are following that 6-month rule. So like I said, St. Jude already has a transition program in place, which we can say is mostly successful, getting more than or about 88% following that 6-month rule, and then 12% extending past that 6-month guideline. So in the transfer program at St. Jude, we actually have transition care coordinators that are calling and scheduling, they're scheduling that adult visit to be 30 days or 1 month after their last pediatric visit. So of course, inevitably, the visits sometimes can get canceled or rescheduled. So that's what leads to having longer than 6 months. But ideally, they all fall within less than 2 months, which is what we're seeing here in this sample. As far as insurance goes, majority of them had public insurance, 8% were not insured, 75% had used hydroxyurea at one point in their life, and then 33% had ever had a chronic transfusion. So when we look at these rates, this is rating, this is modeling the inpatient encounter, so hospitalizations in adult care. And so we use the less than 2 months transfer gap as the reference period, or as the reference group, and modeled this so as we see as the transfer gap increase, so greater than 6 months of transfer gap, we see an increased rate of inpatient encounters, so twice the rate of inpatient encounters in adult care if you had a longer transfer gap. And as you can see, we modeled this 2 separate ways. One, just looking at the first 2 years in adult care. So seeing more of a short-term effect of as soon as they transfer to adult care, we're just looking at those first 2 years. And then also looking at the full follow-up of what we had available. So up to 8 years in adult care. And as you can see in this model, we see they're very similar. So there was no difference between the short-term effect and the long-term effect. So there, regardless of how long we're looking at, there's still twice the rate of inpatient encounters. So we see twice as many hospitalizations for those with a longer transfer gap. And then whenever we looked at emergency department encounters, that's when we start to see that separation, looking at the different like a short-term effect versus the long-term effect. So here we see a significant association just looking at that short-term effect. So with emergency department encounters, they are 1.7 times, so nearly twice as likely or twice as high a rate of emergency department encounters in the first 2 years of adult care compared to those with less than 2 months. So we really see that short-term effect of after they have this long gap in care, then they start going to adult care, and in those first 2 years they have a lot of emergency department visits. So that short-term effect is more they have that higher rate rather than in the long term. And then lastly, we looked at outpatient encounters. And so as we expected, we see a decreased rate. So they go to the outpatient clinic fewer than those with the shorter transfer gap. So they're not being followed up with as consistently. Maybe they're not taking their therapies as consistently. Excuse me. So with this, that's kind of taking them down that spiral of worse and worse care, maybe higher disease severity. So in summary, what we're seeing is that those longer transfer gaps of more than 6 months are associated with increased acute healthcare utilization in adult care compared to those with shorter transfer gaps. And so what we can see is that if we have this increase in acute healthcare utilization after this long transfer gap, it's as likely due to the increased morbidity and mortality from having this care discontinuation. So if they have this gap in care, then we're starting to see higher and higher morbidity, and which can lead to, of course, coming in, being hospitalized more frequently, going to the emergency department more frequently, which of course is a burden on the participant to their health, but also financially, and having to miss work and having to miss school and socially. And so there's a lot more. Yes, health wise is a huge concern, but there's also those social implications as well. And so, in summary, we're able to say that these findings do support that current recommendation to engage in adult care within 6 months of leaving pediatric care. However, we would suggest even shorter. Yes, the 6 month is a great mark for the maximum amount of time, but we would suggest to make it even shorter, just to decrease that care discontinuation as much as possible. And then we also saw that both the short-term and long-term effects, that there was some differences there. With hospitalizations, there was no difference, but with the emergency department, we did see more short-term effect there, that they're in the emergency department in those first 2 years a lot more frequently. So this work really demonstrates the importance of having those interventions in place to prevent transfer gaps as much as possible. And so transition programs are really important to implement these interventions. So in doing so, the transfer programs really should be addressing those barriers that patients are facing whenever it comes to transition. So different ways to do this are to make sure that the patients are comfortable with the adult care providers and the facility. If you're able to introduce the patients to the providers, to the different environment as early as possible, can help make this process smoother and improve their comfortability in adult care, and not make it quite a shock when it comes to make that transition. Alongside that, the program should focus on patient education, being able to improve the patient's health literacy, promoting their self-efficacy. All of this can really help to improve that continuity of care during this transition process. And so future studies, I would love to look at looking at more long-term clinical effects of the transfer gaps. Like we said, with the inpatient hospitalizations, we did see that long-term effect still, it was still associated. And so to look at more specifically what clinical effects we're seeing, why exactly are they being hospitalized, what complications are arising due to that transfer gap. But also evaluating those interventions, different strategies of reducing the transfer gap, trying to understand what's a way that we can reduce the transfer gap, and what's something that we can help inform other programs that this is a strategy that they should use or could use to help prevent those transfer gaps. I want to thank all of my co-authors. This was a huge project that involved several, and the work would not be possible without any of them. And I also added my email there in case anyone had any follow-up questions that they wanted to send me an email and chat more about the work. So yeah, I would just love to hear from you, and thank you guys so much for listening, and thank you to Stephanie for inviting me.
Thank you, Kristen. That was absolutely amazing. Really appreciate your presentation. So now we open the floor to questions. If you either want to put your question in the chat, or if you want to raise your hand, then we unmute you. I'm really curious because maybe I'll start off with a question whilst people are still thinking about it. I'm really curious because in the publication, you're obviously saying that 88% of the patients had a sort of transfer gap within the guidelines, and I'm really curious, like, obviously about the program that you mentioned at St. Jude's. Like, what do you think are the key aspects from that program that really drive that success?
Right, and that's actually exactly what we're investigating right now. We're trying to kind of tease apart the different components of the program. Fortunately, at St. Jude, there are so many resources that we were able to throw everything possible into the transition program, which makes it work successfully. But we know that not every program can do as much as that. And so we're trying to kind of tease apart the different components and understand what are the driving factors. We do have transition care coordinators who this is their job to make sure that this transition program is, or this, that the patient is being educated, and they make that transition as smooth as possible. They kind of do a field trip with the participant and take them over to the adult care facility, meet the doctor, meet the nurses, and get more comfortable with that environment. So there's several different factors that are different components that St. Jude does, that we don't know exactly what's the most important one, or what's, making the biggest effect. So that's one of the projects that they're working on right now, is to try and figure out which one is that driving force.
That's amazing, yeah. Well, complementary to that question, maybe, like Petrus Contouris from Cyprus is asking, do you think that this can be generalized in other centers or in other countries, for example, in Europe?
Right, and I think that'd be something absolutely worth investigating. I am curious to see, and maybe if anyone has a perspective on this in other centers, what transition programs look like for you. For the United States, this is something that has kind of been in the works for a few years, so I'm curious if other centers have also been working on this as well. I do think that this is something that, if there are these transfer gaps, I do think that would definitely be generalizable, or would likely be generalizable. If we have, I think we can expect to say, if we have a discontinuation of care at any point in their lifespan, that we would expect to see, some harsher results once they finally come back to care. However, even in this time span, as we talked about, it's just a very vulnerable time point in general. So even if it's not necessarily from 18 to 20 years old, this gap in care, maybe if it's even from 25 to 26, whatever age gap we would expect to see as they return to care, have some complications arise.
Thank you, Kristen. We also got another question from Vele Labag. Do you organize a combined outpatient visit where the patient is seen by the adult and pediatric hematologist together?
Yes, actually. So they have this program at St. Jude called a co-located model. So actually in those first, I believe it's about the first 5 years of adult care, the pediatrician and the adult hematologist both work together. And so maybe not always seeing them at the exact same time, but it's definitely a combined effort, where the pediatric team goes to the adult facility to make sure that everything is kind of staying on track. And so they have, again, this is a model that might not be able to be replicated by several institutions, but something that we're testing out to see, is this what's working. And so that's something that they've started testing out, this co-located model of working together, the pediatric team and the adult team together, which has been effective, definitely.
We got another question from Petrus Contouris as well. Did you observe any important differences based on the type of insurance, public, private, or out of pocket?
Right. So we did adjust our models for insurance. This can definitely be a challenging one to include in the models, because it's a changing factor sometimes, especially during this time point, where they're moving maybe from their parents' insurance to their own insurance. For this, we used the insurance at the time of their transfer, so from the time of their last pediatric visit. But this is definitely something that could play a role. Could even dictate what facility they can go to, depending on what their insurance would cover. Majority of the patients are on public insurance. Majority of the patients are low income. And so that ends up being the care that they have. In Tennessee, they have something called TennCare, which is a public insurance, specifically for low income. And so several of the sickle cell patients are on TennCare in Tennessee. And so it's always, going to be a changing factor. It's going to be something that's really important to address. But we didn't see any specific changes as far as, likelihood of receiving care, depending on their insurance. Again, variability was really low, just because the majority of them are already on public insurance, but we did adjust the models for that.
Mm-hmm. Thank you, Kristen. I got another question as well, because you obviously shared the factors that make a successful transition. And I'm actually really curious, do you currently measure these factors? And if so, how could it be done across different providers? Because I'm just sort of thinking also how the information would be shared.
Right, right. And that can be it's defining that successful transition can be really complex. And so it's not necessarily something that check off. Yes, successful. No, not successful. It's more that we're looking for these indicators. And so that's something we're trying to model. So here in the study, just did they establish care in general? And so then another study we've looked at is did they remain in care? So retention of care. So these are just different ways that we can kind of model these successes. And again, it's not a strict definition, but definitely different ways that we can kind of visualize this. And of course, as we're evaluating programs, take into account different factors like that.
And sorry, I have another question as well, because I'm really curious, because across many different countries in Europe, for example, sickle cell is most prevalent in immigrants and they might not be fluent in the local language. So I'm wondering, is that a problem you also have in the US? And if so, how do you deal with that, given the education starts already at 12 years of age, obviously?
Right. Yeah. And this is not necessarily a problem that we've faced, to my knowledge. I do know at St. Jude we have translators available. So I think if this were to be a problem, we have that resource available. I don't know about how this would work with other facilities, if translators are available. Of course, it's important to make sure that the education material is available in all of those languages that you may come across. Definitely.
Thank you. And we also got a question from Joanna Ramos, who said, unfortunately, due to some internet issues, she couldn't see the whole presentation, and she asked if the presentation could be shared.
Yes, yes, absolutely. So if you wouldn't mind just sending me an email, I'd be happy to send this to you. But the recording will be made available. Stephanie will probably send those out.
Fine, yeah. Wonderful. So I'm not sure if anybody else has any more questions.
I can put
If
my
not, you
email
shared
in
your
the
email
chat.
address as well. So if
Yeah.
anyone has any more questions at a later date, then they can always get in touch with you. But thank you so much. It was so inspiring to listen to your conversation today, and like the questions and everything, like, because it's quite encouraging, because it is a big problem. So thank you so much for your work, and we're already looking forward to your future publications and to see you kind of get even more insights into this field. So thank you so much, Kristen. The recording will be available in due course, so we'll be sharing the link once it's available. But thank you everyone for joining. And with the holiday season coming up, we wish everyone a lovely holiday season and a great start to 2025. And well, thank you, Kristen.
Thank you. Thank you everyone for listening. Appreciate it.
All right, take care. Bye.
Bye.